So we're going to talk about the tricuspid valve, and there are obviously less technical issues with tricuspid valve interventions because we don't have a lot of experience. So there's a lot of thinking going on in this field right now in terms of indications and patient selection. So I just wanted to start off with a case. We only have a few minutes to talk, but we'll go as quickly and as efficiently as possible. So it's a 75-year-old lady who was referred to us for severe TR. She's had 2 heart failure admissions for right-sided heart failure, NYHA 3 symptoms. She's had a tissue AVR in the past, AFib, hepatitis C, colon cancer resected in 2010. She's on maximal medical therapy. And her testing showed a mildly elevated BNP with normal liver enzymes, TAPSE of 16, ERO of 41, RBSP of 58. She was cath, her coronaries are normal. She has severe TR. And these were her right-hearted pressures with a systolic pressure of 65, a mean PA pressure of 43, and a wedge of 18, and a cardiac output of 4. So based on those numbers, you probably would say there's a mixed picture of what's going on, whether you think it's left-sided or primary tricuspid valve disease. And if you calculated her pulmonary vascular resistance, it would be elevated based on her mean PA pressure and her wedge and her cardiac output. So this is her right ventricular status here. You can see her right atrium is quite dilated, her right ventricle is dilated. And you can see the patient has severe TR. Now there's a new category as massive TR. So by definition, I think that's a visual thing. So I guess the question for this patient is, now that I've showed you the cases, is there an indication for a surgical TVR? Would you offer this patient a TVR, and what risk would you quote her? I guess just as a show of hands, would you think this would be a slam dunk for a surgical tricuspid valve procedure, whether it be repair or replacement, or would you tell this patient, unfortunately, there's no real surgical option here, and we'll just continue on with medicines, and you'll have to live your life out as it is. Just a show of hands based on the imaging and the history. Would you offer this patient surgical TVR? Okay, so, and in your institution, would the patient have surgical TVR? Okay. So this patient was refused surgical TVR at an institution. They were considered too high risk for surgery. Obviously we think TR patients can live with it for a long time, but we know that, of course, as you progress to severe TR, your prognosis is poor, and it's typically independent of your right ventricular size and function. And if you stratify it based on your ERO, and the number we use is 40 in the literature, and you can see that patients actually who have ERO greater than 40 versus less than 40, they have a much different survival rate, independent of their tricuspid valve regurgitation quantity. So, and if you look at cardiac events, the same thing happens. If your ERO is over 40, you have higher cardiac events going out to 10 years. And interestingly, also, it doesn't matter whether you're symptomatic or asymptomatic. If you have severe TR and you're asymptomatic, you're going to have a worse survival. So we talk about the fact that patients are asymptomatic, but truly we need to also look at their echo parameters, and that will come into the decision-making process hopefully in the future when you're thinking about these patients, because a lot of them are asymptomatic. And as we all know, most of these patients are left alone because the risk for cardiac complications during or perioperatively is very high, and so surgeons typically have stayed away from them. So, we talk about an unmet need in this population, and that's where these percutaneous interventions have been born from. Now, it used to be the case where when patients had surgery for left heart disease, they would typically leave the tricuspid valve alone with mild or moderate TR. Of course, when they have severe TR, typically surgeons may put in an annuloplasty ring. But really, actually, nowadays, the recommendation is it doesn't matter whether they have mild, moderate, or severe TR. And typically, obviously, if your annulus is dilated over 40, you're going to have more than mild, but the recommendation is that they need to repair the tricuspid valve if your annular dilatation is greater than 40. And so a lot of these patients are now having surgical annuloplasty, which is the gold standard rather than any suture type of technique. And really, if you look at it, putting an annuloplasty ring, the freedom from recurrent events is up to 85% at 10 years in patients who have left-sided surgery. That being said, we know that mortality is higher in patients who undergo tricuspid valve repair or replacement, but it's actually higher for tricuspid valve replacement. And this was a huge series from the States, and essentially showing that you have up to 14% mortality of patients undergoing tricuspid valve replacement. So it's not obviously not a benign procedure. And again, looking out to 10-year data from the SDS database, again, you're looking at 10% mortality in patients undergoing tricuspid valve surgery. So no doubt there's a clinical need. 50% of patients with a significant MR will have significant TR. And after you fix their mitral valve, a lot of these patients, if you don't fix their tricuspid valve, they'll develop significant TR. We think we think that the TR will get better if it's functional disease, if you fix the mitral valve, but that's not the case in a lot of patients. And essentially it leads to a risky proposition later on if you don't do something about the tricuspid valve, with up to 25% mortality if not done. Also, obviously we have patients who are undergoing mitral clip procedures more frequently nowadays in older population. And this is some recent data essentially showing that if you don't deal with a tricuspid valve in patients who have severe TR at the time of a interventional technique like mitral clip, these patients don't do as well. So it has to come into your decision algorithm in patients who have severe TR who are undergoing a mitral clip procedure, whether you should in fact go forward with it, or if you're not going to deal with the TR as well. So most TR is secondary, typically from left heart disease, pulmonary hypertension, right atrial abnormalities. 25% of it is primary, so either acquired from carcinoid, rarely, pacemaker leads, or congenital abnormalities of the tricuspid valve. And so typically we're dealing mostly with patients with functional disease in this case. The tricuspid valve anatomy is quite complex. As you know, there are three leaflets, the anterior, septal, and posterior leaflets. And the technologies nowadays have essentially been geared towards either the annulus or the leaflets. And typically it's thought that the tricuspid valve dilates sort of from either an anterior, posterior, or an anterior septal way, and the annulus will dilate in that fashion. When you evaluate the tricuspid valve, you certainly need to do TE if you really want to understand the anatomy. And these are some of the views. You would do a mid-esophageal, deep esophageal, and a transgastric view. And also, 3D imaging has been helpful as well, but I'm not going to get into too much detail with that. But the issue with the tricuspid valve is that it's larger than the mitral valve, it's apically displaced, it's oval shaped, it's non-planar. So all of these anatomical issues come into place when you're dealing with trying to fix this complex valve. So I'm going to go into another case. So now we have a 69-year-old female. She's had 3 recent admissions for right-sided heart failure. She's had right breast cancer with radiation and lumpectomy. She has normal LFTs and normal creatinine. Her right atrial pressure was 17, and she had normal pulmonary pressures with a wedge pressure of 15. And this is her RV. So she has severe TR. She has a malcoaptation gap of 17. And you can see her ERO and her TAPSE scores. And her EF is quoted to be 35% of lower coronaries are normal, and you do wonder if this is more of an interaction with the right ventricle, that her EF is actually not as severely impaired, but that was the number that was calculated. So in this case, what would you recommend for this lady? So in the last case I showed you, obviously the right ventricle was a little not as poorly functioning, but in this case, I mean, it's quite impressive that her right ventricle is really not functioning well at all. She's severe dilatation. So would you offer her a surgical tricuspid valve replacement? Would you offer her with VAD backup? And if you're not going to offer her anything that, would you consider her for a percutaneous technique, or would you offer her just a medical therapy? Again, so short of hands, in your institution, would she be offered surgical tricuspid valve replacement? Would the surgeon want to take her on the table? Okay. So again, interesting, because in our institution, this patient was refused surgery again. It's interesting to see what other institutions are doing. So it's very appropriate in terms of what I've seen so far, because if you look at the guidelines, patients who have symptomatic, severe TR should be considered for tricuspid valve repair or replacement, whether it be a primary or functional. So the issue with percutaneous tricuspid valve replacement is that obviously we need to identify the right patients. We need to identify the anatomy that would benefit from this patient. We need to identify the proper timing of the intervention. So there are a lot of challenges when we're dealing with tricuspid valve intervention. So you're dealing with obviously a large angular size and shape. You're dealing with lack of calcification involving the annulus. You're dealing with angulation issues. You're dealing with a complex ventricle with highly trabeculated bands, and you're dealing with a right ventricle that's actually quite thin, not as robust, obviously, as our left ventricle. And you're dealing with a lot of other cardiac structures surrounding the annulus, including the AV node, the His bundle, the proximity to the right coronary artery. You worry about occluding the coronary sinus. And of course, one of the major issues with a lot of our patients is that they have pacemakers and ICDs. And that is a real deterrent from entering into the tricuspid valve annulus. And certainly you have to consider that after the fact too. Will patients need pacemakers? Because we're dealing with an older population, and obviously patients who are older need potentially have more indications for pacemakers. So in terms of what's been going on in the literature right now, there are a number of different devices and interesting technologies, all very early stage, and I'll show you a few of these. But essentially, there's the trick valve, which is a bicable valve implant, where there's been a few cases performed. Essentially, they've created a self-expanding valve, two valves, one in the SVC and one in the IVC. Essentially the idea is to create one big chamber, right ventricle and right atrium, where the right atrium is essentially a reservoir, and prevent obviously the regurgitation into the cable structures. Similarly, there's a Sinus XL, which is the Sapien cable implant, which is using the Sapien valve and implanting a self-expanding stent first in the cava, and then implanting the Sapien valve within the stent. You can do it both in the SVC and IVC as well, but the trial is looking at either or, so either you can implant it in the IVC or implant it in both. There's the Forma device, which is a coaptation surface device, and then you have these cinching devices for the annulus, including the Tri-Align, which is essentially the mitral line system for the mitral valve, the Tri-Cinch device, and then there's some recent data on Mitral Clip being successful in this population as well. So these are just some images of the different technologies. So you can see the bicable valve implant concept, the Forma concept, as well as the cinch concepts. And essentially on the bottom there, you see the tri-cinch concept, which is essentially inserting an anchor along the annulus and essentially tethering it with a stent in place in the IVC and pulling on it, so you essentially reduce the AP diameter. There's been only a few cases of this performed in the world. Same with the mitral line in this position. The outcomes in these few patients have been reasonable, but certainly nothing that is generalizable at this point. And same with the bicable valve implants. There are some early feasibility trials along with the Forma device. So this is the concept of the double valve implant, one in the SVC and one in the IVC. So in terms of mitral clip, that's really gained a lot of interest recently. Certainly there's been cases going back to 2012 or so in patients with congenitally contracted TGA, actually, and some of that work's been done in Europe with some good outcomes in a few case series. But essentially the idea is you're trying to clip two of the leaflets, whether it be the anteroseptal leaflets or the anteroposterior leaflets. You can actually clip, it's been shown you can clip either, all three different types of communications, leaflets. And the results have been reasonable in terms of safety and efficacy. In terms of long-term outcomes, we really don't have any long-term outcomes in this population. This was a study that was just actually published, I had a print, I guess last week, where about 10 centers published on 64 patients where 90% of the patients had severe or massive TR, and they had a good success rate and essentially reduced the TR by mostly 1 grade, and the outcomes were fairly good with only 3 in hospital deaths. That being said, the follow-up was 14 days, so really you can't really say much about long-term follow-up in this population. There was no significant change in the right ventricle. One of the issues with this information is that there was no core lab, and it was strictly observational. But certainly it shows that it's feasible and that it was safe. The Forma spacer device. This is what it looks like when it's inside the tricuspid annulus. So you can see it's an anchored device, and you can see this spacer device that fills up with blood, and essentially it takes up space in the annulus. It comes in 2 sizes, 12 millimeter and 15 millimeter width. They were coming out with an 18 millimeter one as well, but they had problems with it, and that's been shelved for now. But really, they do need larger spacer devices. This was compassionate use for 16 cases. This was published recently. And essentially showed that the device was implanted successfully with a reduction in TR grade and with a reduction in the RA pressures as well. Here you can see the TR grade reduced significantly, actually, which was actually quite impressive. Here's the procedure itself. So you have a large 24 French sheath, and then you have this anchoring. This is a pigtail, just taking a picture of the right ventricle, which is the standard view, so you can appreciate the annulus. And then you have to cross with this catheter here with the balloon up, so you don't get entangled in the chordae. And essentially, you're trying to direct it into the anterior RV free wall and the septum, right at the junction. And essentially, you anchor it here. And so this is your anchoring rail, and then you're going to put your spacer and leave it right in the middle of the tricuspid valve, ideally, so it essentially takes up the coaptation space. So you can see there. The issue is how do you measure the ERO after this? It's very difficult because you just have spraying of TR everywhere. So you calculate the ERO. Typically, what we've noticed that the ERO goes down, but it's really hard to understand if that's accurate or not because it's just all spraying around this this coaptation device. So I think that is an issue going forward with this device in terms of measuring the grade after you're finished. I was supposed to say search your feelings, Luke, but bottom line is the problem with these patients is that they feel fine. You can't really get a history from them, right? I mean, until they are far gone, and then there's nothing you can do about it. The right ventricle is shot, and I mean, I talk, this is an economics principle, but there's this sunk cost fallacy principle where, the damage is done and unfortunately it cannot be recovered, right? I mean, it's the idea is that, you invest in something and you keep investing in something because you're so emotionally invested, but yet it's going down, it's going down the tubes. So it's a similar idea here, like you're emotionally invested in the patient, but, unfortunately you've been watching the patient for so long, the right ventricle is done, and really, your long-term outcome is not going to be good. And we know, I mean, and there's data that shows that, the RV dysfunction is more important than the TR severity for survival. And we have to remember that, really, when we're dealing with this population, because it's coming in fast. So you can't miss the boat, is the bottom line. And I'll just say thank you for that. And it was supposed to be music, but there's no music. And I'll finish there.